is Chris Marr. I am the Director of the Institute for Musculoskeletal Health and a Professor in the School of Public Health. And I'm just going to open the session and then pass on to Professor Cathy Sherrington, who's the next chair. So before we begin, I'd like to acknowledge that we meet today on the lands of the Gadigal people of the Eora Nation. I'd like to pay my respects to elders past, present and emerging, and I'd like to thank them for their custodianship and care of the land that we meet upon today. What I need to warn you about is that today's session is being recorded and photographed. Big warning. And if you don't wish to be videoed or photographed, miss that opportunity, let us know. And what do? We put a red sticker on them. But I think that, yeah, well, the red sticker is probably more embarrassed than having the photo taken. Anyway. So what we're going to talk about today are complex interventions, and it's something that I think a lot of us are really interested in. I mean, I've done drug trials, and I love drug trials because it's so dead simple. You just have a pill and a matching placebo. But in my past life, I was a physiotherapist, and the nature of physiotherapy is it's lots of complex interventions. So I've done physiotherapy trials, psychology trials. I'm also involved in some surgical trials, and so those get us into the area of complex interventions. And we've got some fantastic speakers today who are going to run through some of these issues for us. We've got some speakers from overseas. We've also got, I guess it's a bit of a profile, a bit of a tease of what sorts of trials are happening locally at the CTC and also in our institute, the Institute for Musculoskeletal Health, which would fit under the umbrella of complex trials. And we've got time for lunch as well, and also time for questions. So what I wanted to do, first of all, is to pass to our first chair, who is Professor Cathy Sherrington. Cathy is an IMH and MSK Investigator Fellow at the L3 level, so that's a very, very top, so she's incredibly wonderful. And she's also the Deputy Director of the Institute for Musculoskeletal Health, and I've had the pleasure and good fortune to have worked with Cathy for probably the best part of 2 decades. So could you please welcome Professor Cathy Sherrington.
Thank you, Chris. Thanks for outing how old we are. We're very fit, though, so it's all good. So, yeah, it's my absolute pleasure to welcome our international guest speaker first, Professor Amanda Fahren. And so she's Professor of Clinical Trials and Evaluation of Complex Interventions at the Clinical Trials Research Unit within the Leeds Institute of Clinical Trials Research. She has a background as a medical statistician, and she now, in this role as Director of the Complex Interventions Division, really takes strategic and methodological leadership for an extensive portfolio of trials across stroke, the care of older people, mental health, diet and obesity, cancer, primary care, care homes, and also end-of-life and palliative care. And she also has a focus on evaluating behaviour change interventions. So I think there's something of relevance really for all of our work there. I actually met Amanda when we worked on an unsuccessful grant application together. So it's great that we can get something useful out of that. So yeah, thank you so much, Amanda, for coming to visit and giving this talk, which I'm sure will be fabulous. Welcome.
Thank you very much, Cathy, and thanks for the invitation to speak to you today. I offered a couple of talks and Cathy went for this one. I'm going to do a really, really quick scamper through loads of different ideas about how we can be more innovative in our complex intervention trials. And I've shared a PDF of the slides, so don't feel like you have to take notes or take notes of any of the references because they'll all be available if you want to have those. So I always like to start a talk with a picture, and here's a place that's really close to my heart. It's very close to where I live. It's in one of the national parks in the UK, in the Peak District. And the reason for choosing this picture, you can see that winding road and the ups and downs. And I think that really represents the journey that we have through complex intervention trials. You know, it's not always a smooth road. There's lots of bumps in the way. You encounter things that you don't expect. And I think that's true of trials in general. But maybe this picture is more like a complex intervention trials. There's things coming at you from all angles. and trying to navigate is really quite challenging. And sometimes you just reach a dead end. And what I want to show in this talk really is, can we find a smoother journey, a smoother road through complex intervention methodology, and in particular, can we find a sort of super highway to get us faster to where we want to be in terms of generating the evidence. So you're very familiar, I'm sure, as trialists, about this classical design, a 2-arm parallel group trial, and usually this is what we would adopt for evaluating complex interventions. That's simple, fixed design, separate trials for different interventions, and usually preceded by pilot and feasibility work to understand feasibility and acceptability of interventions rather than provide preliminary evidence of effectiveness. So, as I said, it provides a robust answer as to whether a single intervention is more effective than the control. I'll try and move down get the tech working. But I think the question is whether this standard trial design is really best suited to answering the questions that are most relevant to advancing the evidence base for complex interventions. And I would suggest that the evidence generation in this area has often been slow and inefficient, and I really think we can do better. So, for instance, with this approach, we can't test multiple interventions simultaneously. We can't test combinations of interventions. We don't really have any flexibility to respond to promising new interventions that appear, or to discard futile ones during a study, or even respond to emerging results during the study. So advances in trial design methods provide us really with smarter ways of doing research and increase the number of interventions that we can evaluate given limited financial and patient resources. So what I'm going to consider today are methods for rigorous intervention design, but also early phase evaluation of complex interventions prior to definitive phase 3 trials. I'll consider how recent advances in trial methodology that mainly originates from the drug development perspective, how we can adapt that to suit the needs of complex intervention evaluation. And I'll provide at the end some perspectives on more efficient methods for trial conduct as well. So really what I'm talking about is smarter trials. We still need to get the fundamentals right, but what I think we should be doing is looking to innovate to tackle the challenges that are faced by trials and by health and care services and by society. So by smarter trials, what I mean is smarter design, smarter use of data and technology, and smarter conduct. And I'll try and scamper through each of those in more or less detail. So I'm not sure that I really need to say an awful lot about what I mean by a complex intervention, but to sort of get us on the same page, we typically understand a complex intervention to have multiple components that interact with one another and interact with context, and that there's an element of flexibility or tailoring that is allowed. And I'm sure many of you will be familiar with the MRC framework and this particular diagram that sort of sets out the whole evaluation pathway for complex interventions. So today I'm going to talk a little bit about feasibility and refining interventions, and also focus on the evaluation phase. So as you're aware, pilot and feasibility studies are usually conducted prior to our phase 3 trials, and they're there to inform the feasibility and the design of the main trial. What they really aren't designed to do is evaluate the effectiveness of interventions or provide meaningful effect size estimates. And I think we're missing a trick here in this. So what we have been looking at in Leeds over the last 10 years or so is what sort of methods could we adopt to really give us more evidence that an intervention is the right intervention to evaluate in a phase 3 trial. So which are the most promising interventions, and give us more confidence that we're actually spending our resources on phase 3 trials on the most promising interventions. So one of our postdocs, Duncan Wilson, has done some work in this area, sort of describing how we can adapt the methodology from the drug development world to account for some of the methodological challenges of complex intervention evaluation, such as clustering of outcomes and multiple endpoints. So there's a number of publications on here that if you're interested in this area, I'd do a search on Duncan and have a look at some of his work. And this was really picked up by Alyssa Cahan from Sheffield in the UK MRC funded project that was looking at what are the methodological approaches to developing complex interventions. And through their review work, they identified 8 main strategies. And the one that really aligns with Duncan's work is the number 5 on the screen, the efficiency-based approach, where people have used experimental designs to look at the components within an intervention and select the components that optimize efficiency of that intervention. So trying to find the best package to test in a phase 3 trial. And we've done a little bit of work in this area using different experimental designs prior to phase 3 trials, which I'm going to just quickly run through. And the reason for doing that is really when we're testing complex interventions in phase 3 trials, those components within a complex intervention package aren't usually tested or looked at individually. And what we don't know from our classic 2-arm parallel group trial is which components are making positive contributions to patients. We don't understand whether one component can impact positively or negatively on others. We don't know whether all those components are needed in the intervention package, and whether an individual component within a package, whether its contribution offsets the cost of delivering that component. So if we show an intervention package is effective in a phase 3 trial, we don't really understand those points that I've just talked through. But also if we show it's not effective, we don't entirely know what went wrong and what we can do differently to find an effective intervention. So I just want to talk through about 3 different ways of looking at how we might understand and unpick the contribution from different components within an intervention package. The first is to use a factorial or even a fractional factorial, where we deliberately design the evaluation to understand both the individual contributions of components, but also their combination. And one example from Leeds is our ENACT program, where we were looking at how to optimize both the format and the delivery of feedback in national clinical audits. And we undertook a screening experiment looking at 6 different components of 6 different feedback combinations to enhance the typical clinical audit reports that clinicians receive. On the left-hand side of the screen is the online screenshot of the online system that the experimental participants saw, and on the right-hand side is an explanation of how we were combining those 6 components. So NX said that combination didn't have that modification turns on, and where it's green, that combination of components had those ones turned on. We ran this experiment across 5 different national audits involving 500 participants, and we looked and we asked the participants about their comprehension of the combinations of components that they'd seen, their engagement with the audit and the audit report, and what their intended enactment would do. So once they'd seen the audit report with the combination of modifications that they'd received, what would they actually do with that information? And that work's been written up, and the reference is there on the screen if you want more details. So using that experimental design approach, we can really unpick the contribution of individual components and combinations of components. The second experimental design approach that I want to talk through is the MOST, so multi-phase optimization strategy. And this is the fundamental idea behind this design is that interventions can and should be optimized to meet certain criteria before they then go on to be evaluated in an RCT. And it makes it clear within this framework that that optimization phase is an essential stage prior to the definitive evaluation, and they require different approaches. So you start in the same way as you would with any complex intervention development and evaluation, but the key thing is that you define up front what your optimization criteria are, and then you run this optimization study and assess the results against the criteria to determine whether your intervention really is ready for definitive testing. And if it isn't, you go back through the cycle again. I think the best way of explaining it is through an example. So here's one of our studies from Leeds, the Rosetta program, that was looking at how we help women adhere to medication once they've finished their treatment for breast cancer. And here we are interested in looking at 4 different components of an intervention: reminders through mobile text messaging, an information leaflet, a psychological intervention based on acceptance and commitment therapy, and a website that provided lots of information about side effect management. And what we did up front, you'll see is, hopefully you can see that on the screen, I can't see it very well here, is define what we meant by our optimization criteria. So that was a 2-part optimization criteria. We defined what we meant by an effect. So our effect size was pre-specified, but also there was a component about cost, making sure that we saw effects, but at a cost that could be sustained by the health service. And we've published a fair amount from this study. So there's a protocol and there's papers on the development of the intervention, as well as the process evaluation from our pilot work. And if you want to learn more about MOST, there's a paper here by Linda Collins and Susan Murphy that describes the methodology, as well as it introduces the next design that I'm going to talk through, which is the SMART design. The SMARTs are sequential multiple assignment randomized trial, and here the idea is to construct an optimized adaptive intervention. So here these interventions move away from one size fits all to more individualized patient-centric care. And I think for the clinicians in the audience, these sorts of interventions make a huge amount of sense, because they really align with how people interact, clinicians interact with patients. And the key thing is that they differ from parallel group RCTs and factorial designs, because we repeatedly randomize the same patient over time based on how they're responding to the intervention. And it allows us then to look at adaptations to the intervention, such as dosing or intensity, or bring in different components and understand how individual patients respond to those adaptations. And at the end of that trial, you'd have an optimized adaptive intervention package that can be then evaluated in our more classical RCT design. So again, an example, this has the added complexity of being cluster randomized SMART trial. I don't think there's many of those around in the literature. So one of our GPs is interested in how we work with general practices in the UK to reduce their opioid prescribing, and whether using audit and facilitation helps GPs reduce opioid prescribing. So you can see from here, all practices are currently receiving audit and feedback reports, and at a certain time point into the study, they're assessed as to whether they've responded to those audit and feedback reports. If they have, then they just continue with them. If they don't respond, then they're then randomised either to continue with audit and feedback or to get the additional feedback facilitation. And then another 6 months later, they're assessed again. And again, the responders continue. For those that haven't had the feedback facilitated, the responders continue with their audit and feedback only. But the non-responders, again, are randomised. So you've got a number of different pathways through this, and it allows us to unpick both the effect of audit and feedback alone versus the feedback facilitation, but it also allows us to understand the optimal time to intervene and to add in additional interventions for those who don't respond to the simple audit and feedback alone. And we're also planning to look at whether the baseline characteristics of the practice affect these tailoring variables and the effectiveness of the facilitation. So once we've done that optimization, how do we design more efficient trials? Really have to jump through. I want to spend a little bit of time on cluster trials and then talk a little bit more about adaptive trials. So this is our classic 2-arm parallel group cluster randomized trial. And cluster randomized trials can take many forms: parallel group, factorial. You'll be familiar with step wedge and crossover cluster trials. But what I'm going to focus on now is the parallel group cluster randomized trials. And what do we do when the sort of situation that we find ourselves in means that the parallel group may not be the best design? For instance, if we lose lots of patients from our cluster over time, and this is a big feature in some of our care home trials, we lose people that pass away or move to higher level care or so on. So is it possible to design a robust trial where we identify participants, so the individuals, before and after cluster randomization? That wouldn't normally be permitted in these parallel group trials. Can we allow new participants to enter the trial while the intervention is ongoing? And how do we then link repeated measurements from those individuals over time? So one of my colleagues, Rebecca Warwin, led a methodology project looking at what are called open cohort randomized controlled trials. And we've just got a preprint, so it should be it's certainly available online, talking through how we can design these trials to take account of those challenges and to describe different variants of these open cohorts or more flexible cluster randomized trials. And Laura Marsden there on the screen did her PhD on this topic. And the 6 designs are those established ones where we've got a closed cohort parallel group trial or a cross-sectional parallel group trial. But the new ones allow either a new admission with continuous recruitment during the trial, or these open cohort designs where we either recruit people at specified intervals during the trial or allow continual recruitment post-randomization. So if you're interested in that area, there's lots more information in that preprint. And then I wanted to talk in terms of the design stuff on adaptive trials, and I'm sure many of you are familiar with this, that they're designed to increase trial efficiency, allow us to reach conclusions at earlier stage with reduced costs. Key thing is that adaptations are planned up front. Some of the examples are there on the screen. And I do a lot of work in stroke rehabilitation, and one of your Australian colleagues, Kate Hayward from Melbourne, has recently written a nice paper illustrating how you might want to use adaptive trials in stroke. And I think the message is extend to many areas of clinical work with interventions. So one of the key things with adaptive designs is this the design feature of using interim analysis, so looking at the data, pre-specified intervals against pre-defined stopping rules, and then deciding whether the trial continues or whether you can conclude the intervention has already got overwhelming evidence of effectiveness, or that it's futile to continue in that even if you collect data through to the planned end of trial, you would never be able to show. And for complex intervention trials, the challenges around implementing an interim analysis really link to how long it takes to recruit people and how long you need to wait to observe your outcomes, and whether the timing allows you to fit in an interim analysis and stop the trial early before you've actually completed your full trial recruitment. And then the other issue that is, I think, a little bit more challenging for complex intervention trials is working out what the stopping rule decision criteria is. You're asked to define up front a primary outcome, and the outcome that you use to determine stopping interim. And for complex interventions, we're often targeting many different outcomes. And I think there's a view that if you stop early on the basis of one intervention, what have you lost from your evidence generation? You don't know what's happened with all the other outcomes, and if you'd observed them for longer, you will have had more information about the effectiveness across many domains. So adaptive trials are now moving into a platform trial approach, which again, I'm sure many of you are familiar with. And I think of platform trials as sort of being where you build an expensive sports stadium, and rather than with our two-arm single fixed design trials, you simply play a single match in that stadium. With a platform trial, you still take all the time and money to build the expensive trial infrastructure to the sports stadium, but you play multiple games in there, you evaluate multiple interventions. Much more efficient way of generating evidence. So platform trials are based on master protocols and have various elements, but the key one that we probably focus on in the UK is our multi-arm, multi-stage platform trials that allows us to test multiple interventions, at interim analysis, drop interventions that aren't working or have been shown to be effective, bring new interventions in, and design that in a robust way, so that we're evaluating as many interventions as we can within a single master protocol. And they're compared to individual trials, they're going to be faster, cheaper, and more flexible. But they are much more complex to design and implement. And for complex interventions, I think the challenges are how we define the eligibility criteria, not only at a platform level, but at individual intervention levels. So sometimes we'll have different eligibility criteria for different interventions. That brings us statistical challenges. How we select interventions to come onto the platform. Are they all targeting the same problem? Are we having a platform that is recruiting the same sort of population, but they might be targeting different problems that the patients receive? How we define a control group, and that links back to what our intervention is. Is it plausible to have the same control group for every intervention on the platform, and therefore do we have the efficiencies of a shared control group, or do we actually have to design a platform with different control groups for each intervention? There's challenges around ensuring that we've got a common outcome that works for every intervention on the platform. I think that's much more challenging for complex intervention trials. And as in any other platform trial, the statistics is more complex in terms of assessing the risk of rejecting effective interventions or selecting ineffective ones. And because of that ability to bring or drop interventions from the platform, the total sample size is not known up front, and that can be challenging when you might be recruiting in an area where it's difficult to recruit patients. So having that lack of certainty about what we're aiming for can be difficult. So just a few thoughts around, and I will have said some of these already in what I've just described, sort of key design considerations for platform trials of complex interventions are considerations about which interventions we might want to use and whether how we include patients, whether they're based on subgroups or not. For clinical services, being able to deliver multiple complex interventions or combinations may be difficult. So that's an additional consideration compared to a platform evaluating drugs. And for patients, that voice is really important to understand what's actually feasible and acceptable for them to receive. I've talked about the common shared group and the outcomes, and I've said a little bit about the stopping rules. So I'll sorry, go back. We have a preprint which has actually gone. It's now published at the bottom of the screen, where our work on developing a platform for rehabilitation outcomes after stroke. The challenges and the solutions that we adopted are described in that. And for those of you more from a trial management perspective, some of these are the additional challenges that you would see within platform trials. As you'll know, complex interventions are very resource intensive to deliver. So that issue about deliverability for sites is really important to work through during trial setup. And one potential solution is to consider remote delivery rather than in person. Our experience is that many clinical services delivering these sorts of interventions are not familiar with platform design, so it needs extensive engagement with services to really help them understand the complexities of the design and how it can be implemented on the ground. For participants, essentially we've got much more complex information to share with them in order to help them make informed consent decisions. And our approach has been to suggest staging that information in bite-sized chunks. So it becomes a much more lengthy process to consent patients, but actually people are fully informed and take on information in small bite-sized chunks. Those trial conduct messages are pretty similar to what I've just said. So in the interest of time, I'll move briefly on to the stats considerations. Thought that we might well need to have different eligibility criteria for different interventions within the platform, and that then impacts on the degree of sharing within our control group. So the efficiencies of platform design primarily focus on that concurrent shared control, and if not everyone in the control group can be used as a control for an intervention comparison, that loses some of the efficiency. So it's important to work that through and work through the proportion of people that will be eligible within the control for each intervention comparison. The other thing that we've tried to incorporate within the platform design for complex interventions, in addition to the interim analysis based on sort of statistical decision making on outcome data, is to incorporate some decisions that are more familiar to complex intervention trialists in terms of internal pilot considerations about recruitment and retention, but particularly about the deliverability of the intervention. So if we see that an intervention isn't well received or isn't well delivered, that again may be part of our decision criteria to drop an intervention. There's quite a lot of similar stuff there. I think one of the main things that is particular to complex interventions is clustering and contamination. So when we're designing our trials, we have to think about the level at which we randomise, whether that's at the individual patient level or a cluster level. People are starting to think about cluster platform trials, but I haven't gone that far yet. It feels like a a complexity that is a little bit of a step too far at the moment. So that's one thing to consider. And the other thing around contamination, you go for an individual level randomization, can you ensure that those people who are delivering different interventions don't deliver all of the interventions on the platform? So you would think about mutually exclusive therapists in terms of intervention delivery to sort of try and minimize the potential for contamination. As in any area of developing trials, the patient and care and public involvement is absolutely key. And what we found is that the PPI involvement in developing platform trials really helps us not just develop the patient-facing material, but the patient voice is important in which interventions we evaluate in the platform and which outcomes, but also how we assess whether an intervention should continue within the platform. And we've taken some time to work that through with our patient group, and it's been really valuable. Process evaluations are another part of complex intervention trials, and recommended by various guidance, but they're not really seen in platform trials because they're typically evaluating drugs. So our view is that novelty of the platform approach provides us with an opportunity to do a really interesting process evaluation and lead to sort of more overarching theory around how a class of interventions might work and how which ones are easier or less easy to embed within health service. Moving on, how much longer have I got? Well, 5 minutes. Yeah, I'll scamper through these bits then. So moving away from adaptive design, some other areas of an innovation for complex intervention trials is the more efficient use of routine healthcare data. And certainly in the UK, there's been a big move in this area to trying to use data that's already being collected during healthcare delivery to be used efficiently within trials, either to identify participants and recruit them, or to use it through the intervention process or for follow-up. And you can sort of see the attractiveness of this in terms of where you collect the data once and use it many times, potential for reducing research waste, and the potential, I'm only saying the potential, to be cheaper, faster, and potentially larger trials. But we do need to think carefully about the quality of that data. It hasn't been collected for research purposes. So is it fit for our purpose? The data integrity. And also in the UK, I don't know whether this is a feature in Australia, but certainly in the UK, the time it takes to acquire that data can be really challenging to then be able to use it efficiently within trials. And it was a project in the UK that we led in Leeds and Liverpool, and one of our TMRP PhD students led on this, Alice Marie Toda, where we did some work with many trialists and intervention data providers to think about, if we were going to use this routine healthcare data for trial outcomes, what do we really need to think about? And the paper in Trials describes this in more detail, but in brief, we identified a number of issues relating to the data itself, which are there on screen, but also other issues around terminology that may be different between trialists and data providers. The sorts of skills that you need within the team might be different to our usual trial team, and issues about how we share data and archiving and so on, which are commonplace for trialists, but not quite so straightforward when we're using routine healthcare data. For anyone that's considering using healthcare data for trial outcomes, what we would really urge you to do is undertake some evaluation of whether that use of the routine healthcare data for trial outcomes is fit for purpose, and undertake what in the UK are now known as DUCs, so Data Utility Comparison Studies. So you add a little bit of extra work into your trial, but it allows you to assess the robustness of that healthcare data for trial outcomes, whether it's fit for purpose. And a paper by Matt Sides and colleagues there describes that method in detail. The other area in the UK, and I'm sure it's very prevalent in Australia, especially post-COVID, is about using decentralised trials. And I think in complex interventions, we've often been doing this, but not using the terminology. So it's about moving trial activities closer to home, where we deliver the intervention, where we follow people up, how we recruit people. And I think now there's many more opportunities for using technological solutions to bring the trial activities closer to home. But we need to think about accessibility, patient choice, how we maintain engagement with the trial. And again, I think when we're using new innovative approaches, really urge people to sort of share their experiences and, if possible, compare both the decentralised and the more traditional approach to really generate the evidence base on which approaches work best and where the benefits are of using remote processes. And some of the sort of areas where we might want to think about remote approaches are in terms of how we identify and recruit our population, how we deliver our interventions, particularly with sort of digital health and wearables and so forth, and talked previously about HSD, healthcare service data for outcomes, but there's lots of other ways of getting at outcomes in a decentralised trial. And certainly there's much more interest now in using wearables and sensors. We've started to do this in some of our stroke trials, and I'm sure for many of the sort of physical activity interventions, having a sensor or a wearable that measures an outcome in terms of physical activity is an attractive approach and reduces burden. But again, evaluate whether or not it's giving you what you need for a trial. So there's, oh, that's weird. Well, sorry, there's something wrong with the slide. But at the bottom, there's a paper by Mia Tackney from Cambridge and other trialists in the UK that describes some of the considerations when you're thinking about using digital endpoints, so these remote endpoints in trials, and that's a useful paper. Have a read through, but they, again, as with most papers, they always highlight what the further work is to do, and certainly in terms of adherence and how we use it in diverse populations, we need to do more work in that area and the benefits and the challenges. And then I said I'd say a few words about more efficient trial conduct. And again, I think this is another area where the wide range of technology, especially post-COVID, it gives us lots of opportunities for doing things in potentially a more efficient way across the whole sort of range of trial processes. And there's a potential to minimise the workload of trial teams, potentially enhance outreach, inclusivity, and so on, and very much linked to more sustainable, greener trials with a lower carbon footprint. But as with all of these innovations, it's always important to think about the challenges and the sort of unforeseen consequences. So there's certainly considerations around regulation and ethics and so on in terms of using technology in this way, thinking about those that might be excluded through digital poverty. And I think with most of my experience in trials, we're sort of saying it's not one size fits all, it's tailoring the use of technology to your population and to individual patients within your trial. And with what I've been saying before about e-trials and decentralised trials, again, when we're using more innovative approaches in trial conduct, what we would really advocate for is an evaluation of whether that innovation makes a difference. And by doing that through a study within a trial, I'm sure many of you are familiar with this concept of embedded research studies within your host trials to systematically test different ways of doing things. And for complex interventions, we've been doing this in recruiting and follow-up, but now we're starting to also test different ways of delivering the intervention through using SWOT methodology. And one of our PhD students, Sadia Ahmed, did a PhD, well, part of her PhD was looking at that. There's a nice paper that she wrote there on the screen. And from the SWOT repository, there's lots of examples of SWOTs where you might want to adopt the methods or the tech that people have used and see whether it works for your trial and with your population. And going back and linking the innovative designs with SWOTs, we've started to use the SMART design, so that sequential multiple assigned randomization trial, for testing different ways of increasing follow-up rates and looking at additional levels of randomization for people who don't respond at different points in the follow-up process. And then the final point I want to talk about very, very briefly, it's a big emerging theme within the UK, is about greener trials, thinking about how we reduce our carbon footprint of the trials that we're doing. And some of the things that I've been talking about in terms of remote processes, bringing processes closer to home, intuitively they suggest that that should be a more sustainable way. It should reduce the carbon footprint. But we don't know, so we do need to look at those and really understand what the carbon footprint is of those remote processes. But also within the trials world, we haven't really looked at the carbon footprint of different ways of delivering complex interventions. So I think there's plenty of work and plenty of opportunity to understand that. So I think there's an exciting future ahead for complex intervention trials. The road probably will go up and down, but we're heading towards a bright future. What we need to remember is robust intervention development, think about how we can adopt more smarter designs, enable where we can the trial by data technology and team science, and think about smarter and more sustainable conduct, but always remembering that it's important to evaluate as we innovate. And the move in complex intervention trials, as within many areas of clinical trials, is the move towards more inclusive, diverse trials and doing our trials where the greatest clinical burden is, which will lead, I think, to more innovation and more efficiency in healthcare. That's sort of my conclusion. There's some acknowledgements from my team in the work that we did to look at platform trials of complex interventions, the slide that was for yesterday. But just to say thank you, and happy to take any questions now or in the lunch break if I've overrun.
Perfect. Thank you so much, Amanda. I think that resonated. So many elements of what you said resonated enormously with probably everyone in the room and online as well. So thank you so much. We will move on, but Amanda, so we might not have fully explained the schedule for today. And so we had Amanda first, which was amazing. And then next we're going to have some examples of some trials of complex interventions that are being led from Sydney. And then we've actually got half an hour for lunch. And so I'd invite you to try and tackle Amanda over a sandwich at lunchtime. And then we're resuming for the next portion where we've got Associate Professor Gustavo Machado talking and some closing remarks. And then for those of you in the IMH, Amanda's actually coming up to our offices this afternoon. And so you might be able to trip her up in the office as well later on. So not literally, no. Well, we know about how to respond to that, so it's all good. Fantastic. So, yeah, thank you so much. And so we'll move on now to hearing about some of the current trials. And so we've got three speakers who are going to really give a very rapid overview. So I might introduce them all first, actually, to help our efficiency. So first of all, we've got Professor Anne Tiedemann, who leads the healthy ageing component of work at the Institute for Musculoskeletal Health. Next, we've got Associate Professor Adrian Traeger, who leads some amazing trials of very complex interventions in the back pain area at the Institute. And then we've got Professor David Beard, who we're delighted to have the opportunity to sort of co-host the event with. And so David's Professor of Surgical and Complex Intervention Trials Program at the IMH and MSK Clinical Trials Centre. He has extensive experience with running extremely complex trials in the UK, and we're delighted to have him in Australia now as well. And I'll also acknowledge Professor Meg Jardine, the Director of the Clinical Trials Centre, who I saw pop in, and also Professor Mandy Nickpaw, the Director of the Sydney Musculoskeletal Flagship Research Centre. But now over to Anne, Adrian, then David.
Thanks, Kathy. So yes, as Kathy said, I'm just going to go very briefly through some of the trials that we're running within the physical activity, ageing and disability group first. And so the first one we have here is active women over 50. This is a type 1 hybrid effectiveness implementation RCT. It's focused on improving physical activity participation in women aged 50 plus. It's a remotely delivered behaviour change intervention with a number of different components, including telephone health coaching, SMS or email-based motivational messages, a tailor-made website, and a closed Facebook group. And so we have a waitlist control as our comparison, and our primary outcome is physical activity, which is device measured. And we receive funding from the MRFF to conduct this large trial. So we're recruiting 1,000 women throughout New South Wales, and we're about halfway through our recruitment for this trial. And you can see there's a number of investigators across the university and elsewhere. The next one is Sure Step. So this is focused on inpatients into Sydney-based hospitals. We're testing the effect of an evidence-based mobility program. So it's a 2-week program focusing on improving balance whilst people are inpatients, and with the aim of reducing falls both in the hospital and when people are back home after leaving hospital. And so it's a step wedge trial, also looking at effectiveness and implementation, and it's led by Marina Pinheiro from our group. And it's received funding from the Ramsay Health Research Foundation. The next one is Promote PA. So this is looking at promoting physical activity prescription or promotion by clinicians. So it's looking at outpatient health professionals and patients. It's again a hybrid effectiveness implementation trial, and it's looking at very tailored support. So it's very complex intervention in terms of looking at what the individual clinicians need in terms of their support for promoting physical activity and really tailoring that support to their needs. It's received funding from the IMH and MSK Partnership Program grants, and it's led by Kathy Sherrington. And next up we have Protect. So this is focused on reducing falls in hospital. It's again a step wedge trial, just starting up in Sydney, looking at 12 inpatient wards. And again, the intervention is very tailored to the individual ward level, what they need, what they currently do, and really very tailored and very different for all the different wards that are involved. As I said, it's a step wedge trial and focusing on falls as the primary outcome, but a number of other implementation outcomes. This is led by Kathy Sherrington and Charlotte, who's one of the PhD students within our group. It's received funding from the Partnership Grant. And then finally, Bridges, which is led by Associate Professor Leanne Hassett. This is focused on implementing physical activity guidelines for people with traumatic brain injury. So the lead up to this research was that Leanne received a large grant to develop the guidelines previously, and now this is a follow-on study with, again, a large amount of money from the MRFF, which is looking at implementing these guidelines and evaluating the implementation of the guidelines. I think that's all I've got. So over to Adrian.
All right, thanks, Anne. So my name's Adrian Traeger, and I've got the privilege of presenting some of the work of my colleagues and some of my own trials and my team's trials. So the first one is led by Associate Professor Christina Abdel-Shahid, and this is the COMFORT trial, which is looking at reducing or improving opioid use for people who've been prescribed opioids in primary care. So the complex intervention in this trial is an education outreach visit to GPs to promote opioid stewardship, patient education, and use of non-pharmacologic interventions, and it's being compared to usual care. And they're looking at dose of opioids given over the intervention period as the primary outcome. So this one was funded through the NHMRC clinical trials scheme, and I believe it's beginning recruitment at the moment. The next one is also led by Associate Professor Christina Abdel-Shahid. This one's called SAGE. It's focused on opioids as well, but it's slightly different. So this one, the complex intervention, is GP training in deprescribing and support to facilitate deprescribing in people with chronic opioid use. And this is a cluster randomized trial comparing that complex intervention with the usual care. And they're looking at cessation of the high-risk medicine, which is opioids, benzos, or gabapentinoids. This one was funded through the MRFF. The next one I know a bit more about. This one we have just finished, so we recruited over 3,000 people with back pain presenting to ED. And what we did here with the complex intervention was we used these behavioural interventions. So we put alerts in the ordering system that popped up when doctors ordered opioids for people with back pain, which aren't recommended. And we also put a patient-focused intervention in the waiting area. And we tested these in a 2x2 factorial design. So some hospitals got the single intervention, some got the double, and some got none. And we're looking at the use of low-value care, and this was funded by NHMRC Clinical Trials and Cohort Studies scheme. And the members of the team are shown, some of the members of the team are shown on the slide, but it's also a big team from the Institute working on that one. So we're pleased to be just about to analyse in the next few days. The next one is also one that I'm involved in, and it's a collaborative effort with Minjat Teng, who works for RPA Virtual, and he's a PhD candidate, but he's also a health service manager and senior physiotherapist. So this is a nice example of a trial embedded in routine care. So through Minjat's service at the virtual fracture clinic, and the complex intervention we're testing here is the use of a virtual follow-up, so video calls to follow up people who have simple fractures, and we're comparing that to follow-up care that's provided in the fracture clinic, which is just the usual care in the hospital. So this one is an individual randomized trial, and we received support from MRFF in a grant that covered a few different projects, which was led by Josh Sadro. This one also just finished recruitment, so we're very excited to be following up people at 3 months and seeing how that compared. That was also, I also should say that's a non-inferiority trial. And I have one more to present, which is called the Weightless trial. This one was led by Dr. Josh Sadro from our institute and funded by MRFF, the Nurses, Midwives and Allied Health Scheme. So this is an individual randomized trial looking at a different approach to outpatient physiotherapy care. So the complex intervention here is a physiotherapist-led triage system where you assess people over the phone and you assess their prognosis, and they get a different treatment pathway depending on their predicted outcome, and comparing that to usual in-person outpatient clinic, and looking at physical function, but also waiting time, because it takes a long time to get into these physiotherapy clinics. So, and that work's just getting underway. So that was all I was going to say. So I think I'm going to hand over to David now.
Thanks, Adrian. That's really helpful. I didn't know I was going to give a talk today, so I had to put something together a bit quick. I'm just going to give you a little sort of appetizer plate of some talks which are a combination of Australian, UK and international. It's really wonderful to see so many friends here from CTC, and I'll talk about this a little bit later in my closing remarks, but the IMH, the MSK side of things, and also our international connections and visitors here today as well. So it's really enriching for me. It's great to see. I've got 5 very quickly to do, 2 in current and sort of terminating really and write up, 2 in setup and 1 just pipeline, and they come from various different places. I did put them on a wrong format. Lexi's tried to sort me out, but you'll see a couple of things have dropped off. First one is Reinforce, and that is an evaluation of the rollout of robotic surgery. Robotic surgery is becoming increasingingly popular, as some of you might be aware. And we had this project funded by the NIHR with my colleague Marion Campbell, Professor Marion Campbell, who's here fortunately today as well. We're doing a course tomorrow in Canberra on surgical evaluation. And this was a step wedge design initially. You can see that there. We wanted to see whether there was efficacy, the health economics behind it, and look at the process evaluation as well with colleagues in Aberdeen, and you can see across the bottom there, also in Newcastle. The step wedge didn't work out. It was too difficult. When the robots were coming in, it was really hard to guess. So we ended up going with an interrupted time series design, and we've just about completed that. The specialties we looked at, talking about complex intervention, so you can see them down the side: urology, colorectal, thoracic, gynae, orthopedics, HPV, upper GI, and we've now collected over 2,600 procedures with that. And we didn't know about outcome measures when we set this up, and again with the team in Aberdeen, you may have heard previously, but we looked at a core outcome set for that. It's a good way of looking at something new and innovative in rollout and evaluate it at the same time, rather than wait for it to say yes or no, and then off we go. You can't do that with industry very well, especially big industry like this. There we are, 2,670 patients. You can see our profile on the right there. It was a bit bouncy up and down, a bit in stages, but we got there in the end. That matrix, you don't need to really look at it, but it just shows the different types of sites that we've got. We had ones that were very naive to surgery, to robotic surgery. We had some which were just changing specialty. And we also wanted to look at different manufacturers as well. So we tried to cover so many things. And it has been a really challenging study to do. We're just at the stage of analysis now, which is going to be possibly the most difficult part. And you can see down the bottom there on the left, we thought with the interrupted time series, it would all look like that Cardiff urology plot, where it goes no robotic surgery, and then they convert. In reality, a couple of them did that, but you can see the mess. The blue is the robotic surgery on the right compared with non-robotic surgery. So we've got to extract and do things a little bit clever with that. That's due to be analysed shortly, and we'll be reporting. Second study, which is just in completion, and I want to mention this because it's an interesting phenomenon. It's called NEON study, and it's to surgically repair or not a digital nerve. So when you, I hope you don't, slice through your fingers or wrists or whatever with a chainsaw or something, or a knife, previous wisdom suggested that nerve, the digital nerve, should be sewn together. It was seen clinically that actually that might not be the case. If you just lay the nerve in the gutter, it heals just as well. Perfect question for an RCT. So we set off to look at that. Should you sew it together, the plastic surgeons, or leave in the gutter and see whether the outcomes are the same? It worked. It was a good question. For me, it was actually epitomized uncertainty. But one thing that we got wrong is that we didn't explore with the clinical community enough. And that trial struggled to recruit because people didn't feel that it may have been a professional threat to the surgeons doing that operation. And if I did that again, we would go back and spend a lot more time with that. So if you're doing those sorts of studies, just make sure that you get underneath the skin of it, excuse the pun, and make sure you find out what's going on there, because the trial was poorly recruiting, it was stopped, and it's been a real problem because it's still a fundamental question. The results, just quickly, you show the purple there, the purple box plots are the intervention, actually sewing it together, and a high score is worse for this. So you can see, even with the limited data that we had about 150 in the end, it was showing quite a significant signal that you probably shouldn't sew the nerve together. But we have not completed that fully because the sample size and the power was just under, but we're going to try and roll it out again, and I'm just working with a Vietnamese group in Viet Duc to see whether we can do an additional part to that study and answer the question in more detail. But it's just a bit of a word of warning if you're going to go down that route. Things that are in workup, and you know the team are here, which is great. ACL STAR, This is one of our combination UK-Australian studies with an ACL rupture. Again, what's happened in the past is that they either get left and rehabilitated, or you do a reconstruction, taking a piece of tissue. It's potentially useful to sew the ligament back together in the early stages, but it hasn't been evaluated properly. So we are now just putting together a multi-site study in Australia. There's an equivalent one in the UK to see whether you should do a primary repair or a reconstruction for patients who have just torn their anterior cruciate ligament. And that's going to be quite interesting to see what happens with that. It's an innovative type approach. It's been looked at before, but it's exactly what we should be looking at with surgical interventions to see whether these things work or not. Forensic is something a bit of a throwback. It's a lot of spine people in the room I know, and you'll be half familiar with this. People with back pain in the past used to have spinal fusion to restrict the pain, restrict the movement. And a study way back looked at a head-to-head comparison of that with Jeremy Fairbank and showed that actually the surgery didn't have a lot of effect. So it was taken off shelf in the UK, not so much here in Australia, but it didn't have the distilled and refined sample and population for that. So we've gone back and decided to look at that again, or a group have, of which I'm part of. And we're going to see whether spinal fusion in a much more refined population is worthwhile. And it tends to happen a lot in these surgical procedures. The indications spread, and then you need to bring it back again and see whether it works in a particular group of individuals. So you see that sort of balance occurring quite a lot. But no studies examine that question yet properly when you've got sequential treatment. So people now have to have gone through a really high quality conservative management program. If they're still failing, still having problems, there's not much left for them. It may be that surgery is useful at that stage. So it's end of the line type. And then, so that's just to show you that there's Nadine Foster up in Queensland is looking at the equivalent arm on that, equivalent study on that. It's one of these combined NHMR and NHMRC studies that we're putting together with regularity at the moment. And you can see it's multi-center again, 270 participants. It's got some embedded pilot work and health economics in there, and 270 patients altogether. Last one is the Ninja study, and it's Ninja 2. Ninja 1 was something which we brought the plastic surgeons on board with. They had a very limited heritage of surgical evaluation and trials, but we did this study a little while back looking at whether, and you'd be surprised, it sounds trivial, but it's not, mainly kids in the door, rip their nail off. Should you put that nail back on, sew it and repair the nail bed? And we just examined that as a head-to-head and showed that no, probably you shouldn't. You don't need to repair the nail bed. But the question that the surgeons want to answer was, should we do nothing at all? Should we take them down to theatre at all with all the loops and anaesthetic? And instead, should we just put a bandage on? And actually, that's what we're doing in this next study. And we're going to work that up for the Australian version as well. So it's a question of whether, we had no infection, the cost effectiveness obvious because there's no surgery, and the cosmesis, which is really important, there's no difference. We're now going to do the same sort of thing, but looking at whether you should just bandage it or go to surgery or not. We'll probably have the same issue of professional threat, so we just need to look at that and be careful with that, but hopefully we'll be okay. That's it. Closing remarks, a couple of closing remarks. So, and then we're going to lunch outside. So I'll just go back to saying, it's just wonderful to have these different disciplines and areas of evaluation represented and coming together. I'm part of several of them, and so it's really lovely for me to see all these individuals who've got so much to offer, and groups which have so much to offer, and talking to each other and collaborating properly. There's a lot of competition around, and it's sometimes easy to have competition, but it's much better to have collaboration and actually to work together. And if there's somebody around you, you go, you're doing a similar thing to me, get together, talk about it, make it a unity rather than a conflict a lot of the time. And I think the people that I know in the groups that are here today, and with this unification of CTC and MSK going together, I think it's got some long legs, and I hope it really continues. So thank you for coming. Thanks to everybody for arranging it. It's been really wonderful so far, and I know it's not finished yet, but I'm really enjoying it so far anyway. So thanks very much. This lunch we're having, thankfully, do we need to acknowledge somebody for lunch? Who is it? Do we need to acknowledge somebody for lunch? Sydney Health Partners is clinical academic group. I'm back in as well. I'll let you do that then, Kathy, but thank you for that as well. Lunch, please. See you soon.
Thank you. My name's Connie Vogler. I'm a geriatrician and I manage the musculoskeletal clinical academic group from Sydney Health Partners. So welcome to our second session, and I hope you all managed to get some lunch and saw the possum outside as well, which was great. Just again, a reminder for anyone who's new for this session that today's sessions are being recorded and photographed, so please let us know if you don't want to be photographed, and we can make sure that your photos are deleted if there are any of you. I'm just going to give a very brief overview of the Sydney Health Partners Musculoskeletal Clinical Academic Group. But before that, I'd just like to acknowledge the traditional owners of the lands on which Sydney University main campus is located, the Gadigal people of the Eora Nation, and we pay our respects to the knowledge embedded forever within the Aboriginal custodianship of country. Firstly, an overview of who Sydney Health Partners are. I'm sure you're aware that today this event is co-badged with the IMH and MSK Clinical Trial Centre, the Institute for Musculoskeletal Health, and the Sydney Health Partners Musculoskeletal Clinical Academic Group, which is a big mouthful. Sydney Health Partners themselves are a translational research partnership that's led by health services, and the health services involved are those on our banner, so Nepean, Blue Mountains, Northern Sydney, Sydney, Western Sydney, and the Children's Hospital, as well as, of course, the University of Sydney, and all of the medical research institutes associated with those LHDs. And the mission of Sydney Health Partners itself is to deliver patient and public benefit, to achieve effective collaboration, manage research at scale, and enhance international competitiveness. And Sydney Health Partners has started these clinical academic groups, of which there are now 12, from the major health priorities, and their aim is to support translational research and strengthen research translation. The clinical academic groups are varied and multiple. We have our musculoskeletal CAG, there's the geriatric medicine CAG, perioperative CAG, and we have cardiovascular, cancer, child and adolescent, diabetes and obesity, just to name a few of them. So it's a really diverse group. And our CAG mission for our musculoskeletal CAG is to bring together clinicians, researchers and consumers who work or live within the broad field of musculoskeletal health to build capacity and to provide research-informed care. So just a really brief introduction there. We hold a number of events throughout the year, and just so you're aware, next week there will be an event that's been co-badged by our clinical academic group, the IMH again, and the School of Pharmacy within the University of Sydney. If you're interested in attending, just scan that QR code and you'll be led to the registration page. So now I'll hand over to Arlen, who's going to chair this next session.
Thanks so much, Connie. And thank you so much, everyone, for staying with us for the second half of this special joint event by Sydney Health Partners Musculoskeletal Clinical Academic Group, the Institute for Musculoskeletal Health, and the NHMRC Clinical Trials Centre. As Connie mentioned, I'm Arlen Wilcox. I'm the Associate Director for Trials Development at the NHMRC Clinical Trials Centre, and the usual facilitator of our standard seminar series, CTC Talks Learning. And I get the pleasure of kind of talking us through the finalisation today with our next guest speaker. So it's a real pleasure to welcome our final guest speaker for today's session, Associate Professor Gustavo Machado. Gustavo is an NHMRC Principal Research Fellow and Robinson Fellow at the Institute for Musculoskeletal Health here at the University of Sydney and Sydney Local Health District. His research focuses on improving the care of patients with musculoskeletal pain in emergency health services. His work has been published in top journals and cited over 5,000 times, and he secured just shy of $20 million in grants and received prestigious honours, including the 2023 Research Australia Award and 2022 Australian New Zealand Musculoskeletal Clinical Trials Network Trial of the Year Award. That one's a mouthful, for the SHAPES trial. And Gustavo will be talking to us today about improving back pain care in the emergency department setting. So come on up, Gustavo. Just a reminder for those online, we haven't talked to you specifically much today. Please feel free to pop your questions in the Q&A and we can have a bit of a facilitation of those at the end. But without further ado, here's Gustavo. Thank you.
Thank you very much, Alan, and thank you so much to the Sydney Health Partners, Sydney flagship, MSK flagship, and also the IMH and MSK Clinical Trials Centre for the invitation to talk here today. So today I'll be covering a few trials that I've been involved in, and to give you a bit of an overview. Some of those will have some results I can present on, and some will just be some updates on progress. So back pain is an enormous burden to societies and health systems, and it's in the top 5 main reasons for presenting to emergency departments in Australia, but also across the globe. So if you look at this table from the Australian Institute for Health and Welfare, you can see that that's data from 2017, but over the 7 years since then, every year, back pain ranks in the top 5 or top 6 reasons for presenting to emergency departments. So it's a very common population, patient group that emergency physicians and nurses and physios see in that setting. So first I'll be talking about the SHAPE trial that we have done a few years ago, and that was an initiative funded through the Agency for Clinical Innovation, Sydney Health Partners, and also the IMH and MSK. So back in 2016, the Agency for Clinical Innovation released and published a model of care to manage people with back pain to be used in primary care, but also in emergency settings. And there was a strong message on judicious use of complex medicines, particularly discouraging opioid use, and also using imaging for back pain only when necessary. So, and also like other recommendations for care. So these are the top care, the 10 key principles of care outlined in the model of care. But at that time, we didn't really know how back pain was being managed in various clinical settings, including emergency departments. So in the Sydney Local Health District, what we've done is we designed a clinical dashboard to try and capture hospital data to understand what was happening to people with back pain in that setting. But as you can imagine, to access hospital data can be very complex, and it's because once a patient presents to emergency or the hospital, routinely collected data, all the data that's collected through clinical information, but also orders data for imaging, pathology, and other orders is recorded across several platforms and data tables that are extremely complex to access and to extract and link. But fortunately, we worked with some clever people and managed to create a platform able to link all those data systems and platforms. And we've designed not only a database to use for research purposes, but also a dashboard to engage clinicians and the health service managers and health services on understanding the problems about this patient population. And as you can see here is just a very quick overview of the power of this tool that allowed us to have real-time information about what was happening to people presenting to hospital emergency departments for back pain, including the demographic characteristics, presentation dates and times, but also the treatments that were being given to those patients, including medications, imaging, pathology tests, and everything else. And also costs, like how much those patients were costing to the hospital. So it was a very powerful tool, not only to conduct research in various ways, but also to engage clinicians in the research. One thing that we observed in that dashboard is the overuse of opioids for back pain. So when we saw that data, we saw that about 3/4 of people were receiving opioids in emergency for back pain. But also in Australia, opioid use is a major problem. So you can see that in 2021-22, there were 13.3 million opioid prescriptions dispensed to Australians, to 3 million Australians, and 4.7 million of those prescriptions were related to oxycodone, which is the most used opioid to manage back pain in emergency departments. And we've also seen over a decade between 2002 and 2022 that opioid-related deaths have increased significantly, and now like about 3 people die each day for opioid use. And there is recent data from trials showing that opioids are no better than placebo for acute low back pain. That's in primary care, so there's not much evidence in terms of opioid use and effectiveness or efficacy in the emergency setting. But data from primary care from the OPAL trial has shown that it's no better than placebo in acute back pain. But in terms of in emergency departments, what we saw in some studies is that once patients come into the emergency department, and most of them are opioid naive patients, so like about 2/3 of people coming to emergency are opioid naive patients. They have not received opioids for the previous 6 to 12 months. And once you initiate them on opioids in emergency departments, they're more likely to continue opioids after discharge. So we saw that about 1/3 of them are still using opioids after discharge, and about 1 in 10 are still using opioids after 1 year. So in the SHAPE trial, we've designed a stepped wedge cluster randomized trial to implement the ACI model of care for back pain across 4 emergency departments. So that implementation was sequentially and randomly implemented across the hospitals. We had a baseline control period of 12 months, and then at each month, we've implemented the model of care across the 4 sites. And we also had a follow-up period after that to understand what happened after implementation. So the implementation strategies comprised mainly of 3 key strategies. So the first one was to deliver educational sessions and resources to emergency physicians and nurses and physios. So we've educated or provided training to 300 emergency clinicians across that study period. We've developed a range of resources for them to use. So for example, like a checklist on how to manage back pain, so they could attach that to their lanyards. We've developed and recorded and developed videos recording emergency physicians, but also patients so they could share their experiences. And those videos were shown to various participants in the trial, the clinicians participants. We've developed posters that were placed across the emergency department to raise awareness of the risks of using opioids for back pain. And we also had chief executive support to do this trial, which was very helpful to get the buy-in from emergency physicians and also the emergency nurses to support us. We've developed patient fact sheets that have been translated to over 10 languages, so the clinicians could use those resources to educate their patients. And also online tools for clinicians and patients so they could access several resources to educate the patients. So clinicians could use that to educate the patients, but also the patients could access a range of resources online as well. Very importantly, we've provided the emergency clinicians some non-opioid alternatives. And one key element that we used was the heat wraps that have not been used in emergency for a number of years because of risk of burns. The traditional hot packs have been banned. But this is a safe approach because there is, very low to zero risk of burns. So that this was implemented as a non-opioid alternative to be used in managing people with back pain. So the nurses could initiate patients at triage or after triage, and it would give them the heat wrap straight away. But also we've discussed and came up with a consensus of a list of non-opioid medicines that emergency physicians could use to manage back pain. So we've provided them these alternatives. We also use the dashboard that I've shown you before as a very powerful tool to engage the clinicians and provide them feedback on their clinical performance on opioid prescribing, but also on the use of imaging and hospital admission. And as you can see, we've engaged them in several ways. We've used that tool to engage them during educational outreach and also during the educational training, but also through like posters that were placed in the tea room so they could see how they were progressing alongside the trial, like in terms of the clinical activity, and also through email newsletters that were sent to the emergency departments every month. So in terms of the results, so we saw a large and significant reduction in the use of opioids for people with back pain, which is the top line there. And the effects on imaging and hospitalization were a bit uncertain. But very importantly, what we saw is that after we've done some secondary analysis on on the use of opioids, we've seen that the clinicians did not switch from opioids to risky medicines like benzodiazepines or gabapentinoids. They actually shifted away from the opioids to use simple analgesics recommended in the guidelines. So that was quite, we're pleased to see that. We actually saw a reduction in the use of benzodiazepines, a significant reduction in the use of benzodiazepines as well. The implementation strategies have been shown to be cost effective. And importantly, we've shown that although we've reduced the use of opioids, that did not impact on patient outcomes. So patients, they had adequate pain relief and also highly satisfied with the care they received. Our training to clinicians also shown that we've improved clinicians' knowledge and skills in providing care to back pain. So after we've published the trial, we've received a range of awards and recognition in several ways. So the trial was awarded the ANSMASC Trial of the Year Award in 2022. We've published a paper in BMJ Quality and Safety, and that was selected by the editors, one of the top 10 articles of 2021. We were finalists in the New South Wales Health Awards for value-based healthcare, and the tool we developed, the dashboard we developed, was awarded the NPS Medicine Wise eHealth Award, Excellence in eHealth Awards back in 2018. And we received from the Chief Executive of the Sydney Local Health District a Quality Award for the innovation in the SHAPE trial. And back in 2023, we received the Health Service Research Award from Research Australia. So we had widespread media attention that reached almost 11 million Australians across 200 media outlets reporting on the results of the trial. And you can see the big boss there on the screen being interviewed by several media outlets. We also on the radio, several newspapers, and some specialty medical websites as well. In terms of impact, so the SHAPE trial really provided like a framework for ACI to implement the model of care across all emergency departments in New South Wales, and that implementation strategy was published in the ACI website. So other departments could access what we've done. So in the December last year, the hearing for the Special Commission on Inquiry into Healthcare Funding discussed the SHAPE trials as a successful case study of implementation for over 45 minutes, which was quite interesting, and was very, very glad to see that. And you can see Don being there representing Sydney Health Partners and talking about the SHAPE trial. And the SHAPE trial results also informed the development of the Australian Commission on Safety and Quality in Healthcare clinical case standards on back pain. Our intervention has also been implemented. Our implementation strategy was implemented and evaluated in Royal Brisbane Women's Hospital. The study has been completed with some very exciting results, but I'll maybe leave the investigators to share that in the future. And also, like, I think importantly, it's sort of leverage funding. So like since we've started the SHAPE trial, we've sort of leveraged, nearly $15 million in more research funding through IMH and MSK and MRFF. So the next one I'm going to talk about is the RPA Virtual Back at Home program. And that's being funded through a HCF Research Foundation grant. So as I've explained before, the SHAPE trial also was trying to address the issue of high admission rates for back pain. And what we've also found through the dashboard we designed is that a lot of people with back pain come into emergency, they end up being admitted to hospital. So in Australia, about a third of the people that come to emergency for back pain are subsequently admitted to hospital. In private hospitals, it's higher than that. So in some private hospitals, half of the people get admitted to hospital. So Australia has high rates of hospitalization for back pain, 690 per 100,000 population. So that's 177,000 people admitted for back pain each year. And when you look at the costs, it's really hospital costs that's driving the healthcare costs for back pain. So what we've done is we've published a paper in the Lancet Rheumatology discussing the issue, because it's very rarely discussed in the back pain field, the issue of hospitalizations. So we published a paper with the question, whether back pain is a target for reducing hospitalizations. So over a number of years, we've designed a model of care with RPA Virtual Hospital, which was really like a very thorough co-design between us, researchers, and the clinicians and health service managers at RPA Virtual Hospital, and was also informed by evidence. So over a 3 or 4 year period, we generated a lot of evidence through observational research and qualitative research that trying to understand the problem, and that informed this model of care. So this is just a diagram outlining the flow chart, how the model of care works. I won't go into the detail of this, but you can see that the purple boxes are the new pathways for people. Like, it's a new option for emergency physicians to refer patients to prevent hospitalizations. So in a nutshell, people were eligible for the virtual hospital admission if they were aged between 16 and 70. People over 70 were accepted or referred to the back at home program on a case-by-case analysis. They had to be diagnosed with acute non-serious back pain and also be able to be sent home with support. And we designed a very efficient referral process where ED consultant call the consultant on call at RPA Virtual Hospital to discuss the case and complete a referral form online. And then the patient receives a handout and goes home and is admitted to hospital, is admitted to the back at home program. This study design is a before and after implementation study. It sort of mimics, it's not randomized, but it sort of mimics a stepwise trial, because the implementation was sort of phased across the 3 hospitals. And the analysis will sort of also mimic a stepwise trial analysis. So the implementation strategies involved mainly training the clinicians, the emergency clinicians, on the referral pathway, making them aware of the referral pathway, the new model of care, and also making sure that they understood the eligibility criteria, how to screen patients, and also how to refer patients to the back at home program. So lots of cupcakes, so they to engage them in the conversation. But you can see that it was really well accepted, because they really welcomed the new referral pathway for these patients. We also developed patient information sheets, so patients could take home to understand what was going to happen with them over the next few days during the virtual hospital admission. That has been translated into several languages too. So we, I think we is a lot of people, but I think me and Jet was responsible for talking to a lot of emergency clinicians across a few months. Like, I think it was nearly 280 clinicians that we spoke to. And so the intervention was the intervention in back at home was really based on although like all the patients were reviewed by the medical doctor on call, the medical doctor at RPA Virtual, the consultant at RPA Virtual. After that was a physio-led program. So like physiotherapists were highly involved in the care of those patients. So all the patients received a supply of heat wraps at home. So we saw that they received the heat wrap within a day. So that was a very efficient team from RPA Virtual delivering the heat wraps to the patient's home. And the physiotherapists provided virtual care, encouraging patients to be mobile, be physically active, exercises, advice, reassurance, and also use of apps to help them on exercise programs. So we've included about 203 patients over an 18-month period after implementation. And that's just outlining some of the characteristics of the patients that have been referred to the back at home program. But really what we're doing at the moment is we are analyzing the data to understand the actual impact of the model of care on admission rates and length of stay, which is our primary outcomes for this study. So that's in progress. Next, very, very quickly, I'll talk about the Reshaped trial, which has been funded through the MRFF clinical trials activity. And so these, sorry, not clinical trials activity, the acute models of care MRFF program. And this trial really addresses the issue of the burden that emergency clinicians and emergency departments are facing at the moment with the high volume of patients coming to emergency. A lot of these patients are low acuity patients, and they can, and musculoskeletal is a big proportion of those low acuity presentations to emergency. So musculoskeletal conditions rank 4th in terms of the number of, in terms of the most common presentations to emergency departments. There's 475,000 presentations for a musculoskeletal condition to our emergency departments each year. And as you can see, most of them are triaged as category 3 to 5, which are not as emergency presentations. So they're more like low acuity presentations. And there is evidence from observational studies showing that having physiotherapists to assess and manage these patients as a primary contact clinician can really help to reduce length of stay, increase efficiency, and leave the doctors, the emergency doctors, to manage the more acute or higher acuity patients, which are what they're trained for. But that evidence was based on observational studies, and that was a problem. So all the evidence on primary contact physiotherapy in emergency is based on observational studies. And what we've done is then we've done a review to see, like, are there any randomized trials that have looked into, the effectiveness of having a physiotherapist, acting as a primary contact clinician in emergency to manage musculoskeletal problems. And we found that there were like 5 trials, but none of them had actually measured health services outcomes like length of stay, emergency care efficiency, representation rates. All of those trials were actually measuring patient-reported outcomes like physical function, all of those things. And in a nutshell, there is no difference in patient-reported outcomes whether the patient is managed by a physician or a physiotherapist, right? But that's not a surprise. What we really want to understand is, can we relieve the pressure on emergencies by having a physiotherapist? Can we actually make them get out of the ED faster? Can we make them wait less for treatment? And that's why we designed this trial. And this trial has been done across 5 hospital emergency departments, 3 metropolitan, 2 regional, across Royal Prince Alfred, Sutherland, Ryde, Wyong, and Gosford. It involves 16 primary contact physiotherapists. All of them are level 4 physios, advanced scope physios, so they're experienced physiotherapists. It's open label to arm parallel RCT. And we included patients, adult patients, presenting with a simple musculoskeletal problem like soft tissue injuries, back, neck pain, simple fractures, and dislocations that can be reduced spontaneously. And there's a range of exclusion criteria, but mainly excluded are those that could potentially have a serious pathology or those that would require a surgical review or orthopedic review. So in terms of the trial procedures, so when patients present to emergency for a musculoskeletal condition, they are firstly screened by the physiotherapist for eligibility. If they're eligible, then they're randomized to be allocated to see the physiotherapy first or to see the physician first. That's pretty much what's happening here. But we were concerned about, well, if we make them to consent, and there's a long process to consent, that's going to be a problem in the emergency department. So the ethics committee actually waived us, giving us a waiver of consent for patients to be randomized, because having a physiotherapist in the emergency department is not new. Like, it's already standard of care. It's been in place for a number of years already. So we're comparing one standard of care to another. Our primary outcome is to look at ED efficiency. We wanted to know, can we take those patients out of the hospital faster, out of the ED faster? So the primary outcome is ED length of stay, but we're also measuring a range of other important measures for emergency health service, like representation rates, and also patient-reported outcomes like pain intensity and satisfaction with care and adverse events. The trial has been published, protocol has been published recently, and We have already included 1,449. I think this is from up to February, but I think if you get the stats from last week, I think it's nearly 1,450 participants enrolled in a 18-month period, I think. So like it's been really efficient, the recruitment process. And as I can tell, like it's really using routinely collected data to measure the outcomes, length of stay, that's routinely collected, the primary outcome, and those are the follow-up rates for the secondary outcomes, for the patient-reported outcomes. So lastly, very quickly, I just wanted to touch on the adapted trial, which has been funded through the MRFF clinical trials activity, which is a multi-arm, multi-stage randomized trial assessing a range of non-opioid medications against a common control, which is the oxycodone. So the main objective of this particular scheme was to compare active interventions, so no placebo-controlled trials, to address low-value care. So we know about the harms of opioids, particularly oxycodone, which is the most commonly used opioid in emergency for back pain. So this trial will help us to understand whether there is a non-inferior option to manage these patients in emergency departments. And based on interim analysis and some predetermined rules, we're going to either drop or continue those throughout the study. And I'm having fantastic support from the IMH and MSK Clinical Trials Center to conduct these studies, which has been fantastic. So I think that's pretty much it from me. So I just would like to thank all these amazing people here on the screen, and for their contributions, and also through the partners and the funding that we have received over the years to conduct this program of research. So I think that's it from me. Thank you.
Thank you so much, Gustavo. But before you sit down, maybe I'll ask you to stay up here, and I'll also invite our prior guest speakers up. I know some of you don't know this is coming, but Amanda, Anne, Adrian, and David, if you wanted to come up and join Gustavo for a bit of a panel discussion, a bit of a Q&A with our audience, that would be fantastic. For those online, please feel free to pop your question into the Q&A on Teams, and I will be able to help facilitate that. And maybe if we can get, amazing, 1 or 2 mics for our speakers. So opening it up to the floor, does anyone have a question from today's session for our speakers? Thank you so much, Caitlin.
See if I'm going to go with this.
I need to press that one.
Now we're cooking with gas. Gustavo, this one's for you. Going back to SHAPE, I noticed you had a graphic up there about Concord and this spike in opioid prescriptions again. Did you ever figure out what that came down to? Was it an aberration? Was it a change in personnel? Was there something behind it?
It's a good question. Emergency departments are quite, it's notorious about the rotation they receive from junior doctors. So that really affects, really impacted our, the effects on the opioid prescriptions, because every new rotation, required a new training and outreach to target those new clinicians, the junior doctors coming to the emergency departments. And we saw that, over the years, opioid prescriptions sort of went back up and started to go back to the baseline levels. And that's based on the fact that there's so much rotation happening in emergency departments. So I think the challenge is, how do you sustain that? So it's a big challenge for us.
Thanks, Caitlin. Thanks, Gustavo. Thank you. Kathy. Oh, sorry.
I've got a microphone.
Oh, great.
So I'm going to jump in,
Rachel.
Kathy.
Rachel, then Kathy.
Thank you. This is a sort of a provocative question to the whole panel, on outcome selection within musculoskeletal and surgical complex intervention trials. I've seen, as a health economist, involved in some of these studies, an interest in moving to of efficiency, such as average length of stay, rather than a patient outcome. And I'm just wondering whether that is something that we think is actually the sort of the prime goal, or whether we should be looking at focusing on, a health outcome as a primary outcome. And I'm not criticising any of the trials that do that, and I've worked on quite a few, and I know for health services, efficiency targets and goals are of interest, but I just wonder whether that is what we really should be focusing on. So I'm just interested in, anyone from the panel's thoughts on that.
Excellent. Thanks, Rachel. Really interesting one. David, you want to kick us off?
Shall I kick off with that? I agree with you, Rachel. And I'm not a big advocate of looking at things like length of stay, if I'm honest, in some of the fundamental questions that we look at. It all depends on what the question is about, and to be honest with you. If it's about healthcare delivery, then those things are important, but we all know that they're ever so difficult to measure, and there's all sorts of confounders in things like length of stay. So I have antibodies to it. I also think it depends on where it's driven from. And the question. So again, for the UK, we have got a very big focus at the moment on efficiency and delivering healthcare at cost. And some of those things do come in as questions, sometimes at the expense of some of the clinical questions of care. But for me, I think the care has to come first and then look at the system afterwards.
I mean, I see the cost is important, but that's sort of on the other side of things. You want to know whether what you're paying for is actually delivering something.
Agreeing to it. So I think cost efficacy and efficiency is something, and that is your world, is something that's really important and always has been.
Yeah, I don't disagree with that. I think where we start from when we're looking at evaluating complex interventions is really what is the intervention trying to do? What's the mechanism of action? What's the logic model? And that then leads us on to what are the important outcomes that we should look at. And I think the other thing with trials, I'm sure in Australia as well as in the UK, is really what's important to the patient to change. And my own view is that I suspect they will be saying changing length of stay. If that changes, but it doesn't change anything fundamentally for how the patient feels or their health status or something, that's not going to be what they want the research money to be spent on. So I think it's linking your outcomes back to what the intervention is trying to change, and clearly what the patients are saying are important as well.
Thanks so much, Rachel, and Gustavo too.
It's a good question, Rachel. Thanks for that. Well, I think it's sort of for me it comes to the intervention, the model you're testing, and the goal of that intervention and the goal of that model that you are testing. So like, so I think so choosing the outcomes should reflect on like what is the goal of that intervention, what's the goal of that model of care that you're trying to implement. So I think for some of our trials, have focused on that sort of health efficiency outcomes, because previously they have been shown to be no difference in health outcomes by other trials, but the other trials have not measured health efficiency, so that evidence is lacking, and I guess, so if that question has been answered in terms of health outcomes, then I think the next question is like, can we improve health efficiency? And I think for some of those interventions, that's the goal. It's to increase efficiency, but also keeping track of patient-reported outcomes as secondary outcomes, to measure that as well. So I think that's my perspective.
Thanks very much, panel. Chris?
I think that from the patient's perspective, waiting time can be important. I guess a couple of pieces of evidence. If you look at the newspapers, it's often
horror tales about someone going to the emergency department and waiting for a long period of time. The mum's on a trolley for 12 hours, something like that. I guess the other side of it is while they're waiting for care, they're also in pain. And so I think sensibly done and probably guided by patients, I think you could measure waiting time, and maybe that is important in certain contexts. I guess the other one I'd add in would be waiting time for elective surgery. It often seems to get in the paper.
Can I ask another provocative question for the rest of the panel? Maybe more Amanda and Gustavo, I don't know. Do we think that platform trials compromise the research question? So people drive from I want to do a platform type study, and sometimes it doesn't quite fit. I think the study that you're doing does, so that's Joel's go. But occasionally you go, oh, this is a bit clever design and we need to do something, and then fit the question around it. And I worry sometimes that we're coming from the wrong end, and I wouldn't want everything to go down that route.
I know where you're coming from. I don't think it's unique to platform trials. So what we often get is people coming to us in the trials unit saying, I want to do a step wedge trial, or I want to do this sort of trial, or I want to do this fancy design. And what we always do is we circle back to what the research question is, so that we're fitting the methodology to suit the research question, not the other way around. So I think it's the same with platform trials. If someone said, oh, I really want to do a platform trial, taking a step back, what are you actually trying to do? What's your research question? And then let's work out what's the most appropriate design to answer that question robustly. I'm sorry.
That's all.
You're not allowed to make that question. You're an investigator on that trial as well. But no, I think you got a point. So I think choosing the design, like adaptive trial design, like we get tempted to do those fancy trial designs just because they're novel, and also the guidelines for grant applications, they also say so we want innovative trial designs, and then you get tempted to I'm gonna try and propose this just for the sake of it, or just to tick that box in the guideline. But yeah, it should really come back to the question that you're trying to answer. And I think for our trial, that's going to work really well, because it's going to allow us to answer, a really important question about various interventions that are used to manage back pain in that setting. So it will increase efficiency for sure.
I think my concern was that when the treatment fits the adaptive design, it's perfect because you pop it in. It's when you either shoehorn something in that doesn't fit, or you miss something out of that, which would be normal care, just because it's a platform, and then it may not be the right question. So it's just worth a thought when you're sort of setting it up and going, oh, is this going to answer everything, or have we missed something out of the room which is really important, just because it doesn't fit with the adaptive design.
The other observation that I've got in this sort of area is the point of view of the funder. I think particularly sort of statisticians and methodologists are really interested in, designing studies that have got the new sexy methodology in them. I think that certainly in the UK, I don't know if it's the same in Australia, but I think there's an element of conservatism amongst the funder in terms of their sense of risk and what they're willing to fund. So I think there's also that sort of side of things to think through carefully as well in terms of the choice of methods.
Thanks, David. Thanks, panel. I think just to sum up that discussion, it really highlights fit-for-purpose design, taking a really considered approach based on your clinical question, and talking to those experts as trialists, as methodologists, whoever it might be, to bring that collaborative group to the table to create that design. So thank you. Kathy.
About how we get kind of more support and advocacy for actually doing trials of complex interventions. So as I think Adrian, Gustavo and Anne can attest to, it's very difficult, and our systems are not necessarily set up to support them. So for example, one of the trials Anne talked about was in a recent audit, and the feedback was that, the reporting's not as rigorous as it is for the pharmaceutical funded trials. Really, that's a surprise. But so how, do we get more support and more working together on the methods, but also on advocacy, importance of these?
I'll start on that. Thanks. So I think it's lead from the front is the main thing for me on that, Kathy, whereby we have to do these trials well. And I can only talk from my experience of surgical intervention. I know there's people in the room who've done that as well. We had stones thrown at us in surgical evaluation for a long time. And until the quality of the study comes through, they are very difficult to do. There's no question about it. And sometimes it's much easier to compare pharmacological agents A versus B. So there's some real skills needed to do them. But if you do them well and that's acknowledged, it's a lobbying process from that point on. And people have to kind of stand up and look and go, okay, this is good. If we do them poorly, I think we'll disadvantage ourselves. And I don't see any of them done poorly. So do them well and pick good quality questions.
Yeah, what else can I add to that? I don't see quite as much of a problem. Maybe it's just because I've been in that world for 20 plus years of doing complex intervention trials. I do think there's a challenge, certainly when we engage with different services that maybe are more research naive, that there's a point of view that actually they can't do trials in their area. So I think it's about leading people through in a way where they start to understand how they can work and how they can be applied in their area. And I sort of take the point of view is that our most robust form of evidence generation is in a randomized controlled trial. And it's trying to find a way of ensuring that we can, adopt that rigor in a way that works for that service and provide, the evidence base in the gold standard way. So sort of it's a bit of hand-holding, it's taking people through, it's maybe showing examples of where those robust, well-designed trials have happened in similar areas where maybe it was challenging to do, sharing the experiences and so on. But I guess I always start from the point of view that our best evaluation methodology is an RCT, so let's try and work out how we can do it together.
For your question, have I missed someone across the audience with a microphone? Oh, no, we can go to Mandy. Thank you. Just might want to turn that one on, Mandy.
I just want to pick up on your comment about good quality research. I love the diversity of your research portfolio. Not a surgeon. How do you come up with a research question? How do you decide what is the research question in that surgical space?
I've not really thought about that, if I'm honest. So it's not an instant process. So the key for my work is the preamble to it all and the iterations that go on. So somebody might come in with an idea and it may go out straight away. It may get to the next stage, the next stage, the next stage. And then that process and that sequence, you end up with quite a rich question in the end. Then they're often not my ideas, but what we can do is we can add to it and execute it. And you get an eye for knowing what can be executed, done well. And you also get an eye for knowing what is going to be funded, and you get an eye for knowing what will be delivered and perhaps change practice. We have a belief, and I bring this here as well, that we don't want to do something which is trivial and not going to change practice. If you look at your study and think, at the end of this, it's not going to change anything or do anything, I think you have to really look at that question. There's still room for own account research to learn on things. I think that's important because not everybody can do these big trials all the time, and I see that. We used to do that a lot when days gone by. But there's no real recipe. I think it's about dedication to the cause and just making sure that you distill down to something which ticks many boxes and you go, this is going to be okay. It's going to be changing practice. I don't know whether that really answers your question.
Thanks, Mandy. Any other questions? I might just ask one as well myself. A lot of the questions so far that we've had have been more in this design, thinking about the question, that really early kind of startup work for our research. I want to push us along the train a little bit and think about the challenges in delivery of research within a complex intervention space. David, you mentioned a little bit about challenges in engaging clinicians with some difficulties with clinical equipoise there, or threats to their kind of component of work. We see that the UK healthcare system has robust funding centred around clinical trials in any therapeutic area. Delivering them here in Australia is a little bit different and has some unique complexities. What's on your wish list for the complex intervention space to really enhance efficiency of research delivery here in Australia?
I've talked enough, so I'll just do two things. I'd say one thing. I think it's about having the right people to do it, and making sure that you don't assume anything. As soon as you start to assume things, it'll go wrong. No assumptions, and having good and the right people behind the delivery. And they're few and far between, actually. There's some very good people in the room and elsewhere, but somebody who can deliver a trial well and part of that apparatus are absolutely key to it. And people forget that. They go, oh, I've done the funding, I've got the question, great, sit back and relax. Yeah, that's when the hard work starts.
Thanks, Anne. Yeah.
I would say having a conversation or having conversations with people and putting in the groundwork and getting to know your target, say health professionals, if you're trying to implement an intervention. Yeah, so doing that initial groundwork, developing the trust and helping them to see that the intervention could make their life better, could make their life easier. I think that's been really key to some of our work. Yeah.
Just going to add a few thoughts in terms of how we implement interventions within trials. And I think there is much more guidance in the literature now in terms of how we do that, and thinking through the different processes, thinking right from actually how you design those implementation processes, how you train people to deliver the intervention, what you're training them to do, what they're teaching to the intervention recipient, and what you're expecting the research recipient or the intervention recipient to do with that knowledge or those skills. So I think there's sort of frameworks that we can use that sort of help us really plan that, and also not only plan it, but collect the data to assess whether we're doing that rigorously, assessing intervention delivery, intervention fidelity, what people enact in the intervention. All that information is really important within complex intervention trials to really understand what's happened within the trial, and to put the outcomes evaluation in context, so we understand why we've seen the treatment effect we've observed, or we've failed to see a treatment effect. So I think, I'm a statistician, so I'm always going to argue for more data, but I think there's much more recognition now that the data about how we deliver interventions within trials is really important, rich data to collect. So yeah, alongside the people side of things, data is always important.
Probably a small thought to that as well. Just reflecting on the trials that I presented. So a lot of them are cluster randomized trials with varying numbers. When I think about the ones that have gone well, I mean, there's obviously been fewer clusters, so fewer sites that you need to manage relationships. In our team in particular, we've put so much emphasis on relationships with sites. A lot of our time with delivering the trial is spent out at sites, talking to people, taking them donuts, doing little things, building those relationships. It seems obvious, but I really think that's been a key to success. And when you're faced with a trial like colleague Christine Del-Shahid's trial, which has lots of GP clusters, so lots of little clusters to get a complex intervention, 50 plus GP sites, having those relationships becomes much harder. So that's where I get interested in how we can use innovation and some of the things you spoke about, Amanda, to keep those relationships going, because it's so critical to get all that data to have relationships. I haven't got the answer to that, but maybe the innovation and some technological help there.
Excellent. Thank you so much, panel. I'll open the floor for one more question. Otherwise, we will look to wrap up. Please, everyone, join me in thanking all of our presenters for today. Anne, Amanda, John, Gustavo, and Adrian. David, sorry, Gustavo and Adrian. Thank you so much for the talks. Just some closing remarks from me as we wrap up. I reflected nicely on Connie's slides today, and Sydney Health Partners being one of the collaborators of the session. The mission for the Musculoskeletal Clinical Academic Group starts with the words "to bring together," which I think is a really, really neat kind of setting for us all here as various researchers from different settings coming together and learning from a group of our colleagues. In today's global political climate, I think the importance of working together for a common good cannot be overstated. Today, we've delved into the intricate world of complex trials, complex interventions, surgical interventions, and to piggyback off David's closing reflections earlier, throughout all of these presentations, what I've heard is this strength of coming together and generating high quality evidence through that strong collaboration. I'd like to extend a special thank you to the NHMRC Clinical Trials Centre, the Institute of Musculoskeletal Health, and Sydney Health Partners Musculoskeletal Clinical Academic Group for making this special CTC Talks session possible. And an extra big thank you to Lexi and Tamara, who have been sitting down the front the whole time, who actualised the whole event. It would not have come together without the two of them. As we move forward, audience, I hope you are able to take away some inspiration from our speakers today. I encourage you all to connect with our speakers. I encourage you to connect with the three groups who have facilitated the session, CTC, IMH, and Sydney Health Partners, and collaborate with purpose and collaborate with passion. Lastly, before we conclude, up on the screen, CTC Talks Learning happens every week. This was an extra special session. Please scan the QR code if you want to join any of our sessions. You can get on our mailing list there. Next week, we'll be only online. We've got Associate Professor Nandini Dendakuri from McGill University in Montreal, who will be discussing latent class analysis for diagnostic test accuracy evaluation. So please, we look forward to seeing you there. But thank you so much, everyone.